Methylene blue, I typically never will give more than 5 milligrams. Here is the issue with first thing is it will turn the urine quite blue.
You know, there was a study that recently came out. There being toxins, microplastics inside of these IV bags. How do we prevent those microplastics from going inside of our patient?
Okay, so we have two issues.
We have the true OG behind IV therapy, Dr. Mitch Ghen.
Joining us is Dr. Mitch Ghen, DO, PhD researcher, international lecturer, and one of the most respected voices in IV nutrition and stem cell integrative medicine. With 4 textbooks and decades of clinical work, he's a true pioneer.
Of the 37 trillion cells, we have trillions faults or problems. Body typically 99.9% of the time fixes it, but we have 1 to 10 per cell double-stranded attacks. Any one of them could turn into a cancer.
Are you able to do a precision vitamin IV therapy IV based off epigenetic testing only?
Looking at the epigenome itself, there is absolutely no way you can tell what's happening and what IV you're going to give that person.
What is the difference between a physician really utilizing IV nutrition versus people go in and they're almost like picking off a smoothie menu type of deal?
I hate that. I think
Welcome to another episode of a Healthy Point of View podcast. I'm your host, Sam Tejada, and as usual, we're bringing experts from all over the world to talk about health, wellness, beauty, and mindset. Today's guest, he's a local here in South Florida. But, you know, a lot of you guys always ask me, Sam, how did you and all of your guru doctors learn about IV therapy? Well, there's people out there that are the true gurus behind IV therapy. These are the OGs in the industry where everybody really started learning, the ones that are willing to take the risk. Today, we have the true OG behind IV therapy. You've probably seen him on so many different stages around the world. He is the guy who's not just an expert, he creates experts in IV nutrition. Today, we have Dr. Mitch Ghen. All right.
Well, if I didn't know that you were Sam, I'd have thought you were my mother talking. Thank you. Thank you
Moms
for the interview.
are always nice. I get that.
Yeah.
But, you know, everything I said about you in that introduction, it's true to my heart, and it's true to who you are as a person in this industry. And anyone who is in the IV therapy industry who doesn't know who Dr. Mitch Ghen is, that's a problem. That means they really don't understand what IV nutrition is as of yet. After this podcast, they will understand truly what you do in the world of IV nutritional therapy, especially being an author of many of the textbooks that are out there, right? So, Dr. Ghen, I want to start off with people, forget about all this doctor and IV therapy stuff. I want people to get to know who you are and who was that 5-year-old Mitch Ghen, and what was going through that 5-year-old mindset to get to where you're at today?
You're talking about the 5-year-old. I was probably thinking about Sally, my next door neighbor, to be quite frank. But, you know, things change as you get older. I think when I was up to 11 or 12, I can remember the best gift I ever got for the holidays was actually a chemistry set. And they called me like the mad, crazy chemist. I would make this and that and everything under the sun. And I knew at that point, something about this industry was fun. I even had gotten from a neighbor who was a pharmacist some powder that helped you fall asleep, you know, things that they used back then, not ether, but one of the others. And I decided to actually anesthetize one of my friends. This is 12 years old, mind you, and I knocked him clean out. Of course, I was a little worried because I was no anesthesia, but then he came back and I'm saying, I like this, and this is probably where I'll go. And as time went on, things changed. I went through schooling, basically started off with a bachelor's of business administration and thought I was going to go to law school. And I decided, not for me. What was really for me was getting into medicine. But at that time, I was a phys ed director of the largest Jewish Y in Philadelphia. And it was a late one night, about 11 o'clock. I go upstairs and there's a wonderful, and I hope she's still around and doing well, secretary. And I was like totally down in the mouth. I closed up the place. She said, Mitchell, what's bothering you? I said, I really hate what I'm doing. She said, if you could have done anything. Now, mind you, at that point, I'm already 26 years old.
Right.
She said, if you could done anything at that point, what would you do? I said, I should have been a doctor. She said, well, why don't you? I said, because look, I had a kid when I was in college, early college. My college grades were very fair. I'd have to go back. I'd have to get my science courses. And this woman said something to me, Sam, I think about at least once a week.
Oh, wow.
And something I think that the people watching this, it's important to hear. She looked at me and said, Mitchell, do you ever want to look back when you're 60 and say you're sorry? I didn't say a word. I couldn't breathe. I left the next day. I enrolled in St. Joe's, which is one of the big five, as you know. It is the college in Philadelphia that if you can do well in, you do well. And thank God I walked away with a 4.0 average in my sciences. They saw I was a different type of person. There I am. Went to medical school, and that's how it all began.
Wow. Amazing. What was your upbringing? What part of the States?
Northeast Philadelphia.
In
I'm from
Philadelphia.
Philly. I'm from Philly. I was in Philadelphia all through college and also through medical school.
Okay.
From there, I migrated to Florida for a couple of reasons. My parents were going back and forth, and they had a place down here, and I enjoyed coming. And the other thing was great about medicine, as you know from being in the healthcare profession yourself, that you can go anywhere.
Right.
Medicine's universal, at least in the States. And I said, that's what I want to do. And
Nice.
got myself together, and off I went to Florida.
Amazing, man. Philadelphia. Will Smith is from Philadelphia.
Yes.
Philly. Yeah,
Yeah.
yeah. The so the business degree, and one thing that I've always noticed with you, Dr. Mitch, is that you've always had like it's one of the things that it's talked about in the industry quite a bit, in the medical industry. Doctors are great doctors, but not great businessmen and women.
True.
But you have that business degree, and I've always noticed like you always have that business mindset as well too. Not just to capitalize financially, but also making sure that your patients have the best experience possible.
Yeah, and there's a couple things that go along with that, Sam. You know, most people that go to medical school, they're young. And they really didn't have the capability of sort of enjoying life as a young person, going out enough. They were, shadowed. Were in the house. They were studying for tests. So I had the advantage already being a little bit older. The second thing was I know that doctors have a difficult time, as you know, you work with so many, talking and discussing economic situations.
Right.
And they're very poor businessmen, as we all know. And, I do a lot of consulting. I teach a lot of doctors. And the one thing I always talk about is it's okay to make money, doc. It's all right. You don't have to be, oh my gosh, and a lot of doctors are that way. Unfortunately, they feel uncomfortable. But the way I look at it, Sam, is this. I do a good job. I do my best. I believe that I do the kind of job that people are looking for. I deserve to get paid for what I do,
Absolutely.
like anything else. And I myself personally have been a cash practitioner probably for more than 21 years now. So for me, I go to sleep at night. I look back over the night. I say to myself, Mitchell, did you do a good job? I look up and I said, God, please just give me the gift of understanding, knowing what to do, and make sure I do a good job tomorrow. And that's me. And I feel I get paid for what I do. And
Amazing.
It's fair. It's fair.
I agree. I'll never forget one of the classes that you were teaching that I participated in. You and this stuck, and I till this day I actually take what you were teaching in that class, and I coach a lot of our team members with it. And you put a lot of emphasis about how it's important as a medical provider to connect with your patient and make them feel connected and comfortable. And you even literally took a chair next to someone and you sat next to them and showed them, like, don't be scared to touch your patient. Put your hand on them, look at them in the eyes, and tell them that we're working on this. We're going to get through it. And these patients, a lot of them, especially the ones that you work with, are very ill. Right. And they're confused. They don't know, they've seen multiple doctors by the time they get to you. So, seeing those things. And another thing I remember you saying as well, too, was when you, as a physician, you see so many patients. And we have a lot of physicians that tune into this podcast. And this is why I want to bring it up. You even mentioned that when you're taking your notes, your patient notes, don't just use it for the medical stuff. If they're telling you, hey, I'm coming in and, I'm going on a vacation with my kids or I'm going to Disney World, jot that down inside of the patient chart as well, too. So when they come back, you remember that and you can ask them about it.
Sure.
But these are the little things that I feel like most doctors don't even, recognize or do any of this. Like, what makes you, like there's a whole psychological component with what you're doing.
And I think there is no question. Medicine is a good portion, a psychological component to it. Look, the day of the EMR has made a mess of that. Doctor looking at the patient, talking, they're looking at the screen. I always took my notes, Sam. Now I use something that literally transcribes, listens to the conversation, AI. I get permission from the patient, and I can spend my time looking at the patient. I think in the same conference that I talked to you about, I also taught that in the first 14 seconds of meeting someone, that patient already knows if they like you or not. If you're on a scribe or you're on this or you're doing that, it doesn't show very good, manners or conduct to that patient. You get up, shake their hand, say hello. And you're right. I always thought, and I still do, that you should treat your patient as if it was your mother. You should be nice to them. They're having a problem. They came to you and they need your help. Now, I see, as you said, I see the very, very sick. A good portion of my patients are referred from other physicians throughout the country. And these people are really looking to me as the last ditch effort that they have. And I think it's worth the time. It's worth the effort. You don't have to sympathize, but you do need some empathy in this space. You need to take your time. Some people need a little more. Some people need to know that you're there. Some people need, to let them cry and let them go through this. And I always ask similar questions. One of the first questions I ask someone after I know their name and so forth is, tell me if Mitch can do anything for you. By the way, I don't do this doctor stuff. I don't do anything. I don't care. I'll say, if Mitch could do anything for you, what would that be? And so I let them tell me. I be quiet and I let them tell me, well, if you can help me with this, get rid of this or do this. I said, okay, well, you know what? God's given me a great gift and God will be with us. And yes, I think it's okay for me to say that. And I don't care if it's not, they don't have to use me. But I believe that there's something extra and greater than the physician themselves. And with that help of that extraterrestrial being, whatever you want to call it, care, plus what you know and what you study. And if you always keep studying, then you're doing really the best. So like I said, when I go to bed at night, I always think back over the day, what could I have done more? What could I have done less? And sometimes I'll even call a patient back and say, but like I said, you need to treat human beings like human beings.
Right.
That's what you're in the world. I've been doing this over, 44, 45 years now.
Wow.
So for me, it's a pleasure to do it. I do it because I believe I have a purpose in life to be there for these folks.
Amen on that, man. Is that, I know how you feel, and I know how I feel about bringing faith and God into the picture, especially dealing with patients. And when I worked at the fire department for 12 years out on the road as a firefighter paramedic, it was something that I would even pray over patients if they allowed me to.
Good for you.
How important is that, including faith in God into this realm?
Well, I'm cautious. When I teach, I always teach my physicians. There are two subjects you never should really broach with a patient unless you're on the same side. That is politics and religion.
Right.
If you say something to somebody and if they're totally in opposition to what you say in those two areas, all they hear after that is blah, 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 blah. They don't hear you.
Right.
But it's very rare when someone is really sick that they don't want someone to bring that in. Look, everybody you probably remember when you started, had the triangle of, mind, body,
Oh, yeah.
spirit. It's a very nice triangle, but do you practice it? And, maybe you do know, I'm not sure if you do know. I was in medicine for several years and I knew I was missing a component of this. And I was in South Carolina at the time. I had 3 practices there. And I said to one of the priests, I'm Jewish. I said, I read certain things and it says just do it. I don't understand why. Why do I have to do something it says? And he said, listen, my son, there are things that you have to do because it says so. So I said, okay, I'll ask a minister. I asked a minister pretty much the same thing. And then I asked a very religious rabbi, one of the Chabad rabbis, and they told me basically the same. So 3 of them, I said, you know what? Nah, I'm not buying it because I have a logic system. And I went back and did 3 years in a rabbinical seminary while I was still a physician.
Oh, wow.
So, because I needed to find my own space in this, because I realized what you think is what you get. What
Right.
you see is what you create. And you know very well, and you know from being in this space so long, a patient with the worst disease imaginable, whatever you want to call it, that knows they're going to do good, has a great attitude, says, I'm going, and they have a great, they do much better every
Absolutely.
single time.
Yeah.
So, yes, that's how this all crawled into space with me. And I realized that it was something, if I wanted to purvey the best medicine and be the best mentor and guide to these patients that come to me that are so ill, I need to first find myself and feel comfortable in this space. And I'm not uncomfortable talking to a patient about pretty much anything. I'm not. And I've been doing it too long to be uncomfortable. But at the same time, I want that patient to say they're comfortable when they leave too and say, yeah, I think I'm going to be okay.
Yeah.
And that's the best thing.
Yeah, that's powerful. And what you just mentioned about the patient having that positive mindset and how that can feed to even a more powerful outcome with their health. You know, Dr. Joe Dispenza speaks about it quite often, about how powerful the mind is, you know, if you have the mind in the right place. So, Dr. Ghen, IV nutrients therapy and regenerative medicine. No one goes to college, medical school, and says, "Oh, I'm going to be the expert in IV nutrition." How the heck did he even get there?
Oh, I could tell you the good story. You want to hear the truth? The
I
good
want to
story?
hear.
45 plus years ago, I was the chief intern of a hospital in Florida that's no longer there. I think it's been torn down and made into some sort of nursing home. I was the chief intern at the time. We were 11 in my team. So I noticed that there were certain individuals getting out of the hospital much faster than others with the same exact disorder.
Mm.
So I started looking at who the internal medicine group, family medicine group that were handling these people. Makes sense because here I am. I just want to know what's going on. And so it came, and so often, so statistically prominent in my head that they were using, the group that was getting the people out of the hospital much faster, they were using back then 50,000 milligrams of vitamin C intravenously in a hospital. Don't faint.
Oh, wow.
It was true.
Okay.
So I said, wow, that's certainly different than the way I was trained originally, because in medical school, and pretty much the first week or two when you're doing biochemistry and physiology, one of the either, they would get up there and say, you know, all this vitamin C, it doesn't do any good. It only a little bit you need. So we're going to do an experiment, go urinate, call that one, go take 500 vitamin C, check again, and you see a lot of it's in the urine. Yeah, that's far-fetched from what it really does, but that's something we can talk about later if you choose. But then I saw this happening. I said, something I didn't learn in medical school. And that's what started my journey so long ago into this. I realized, and then of course, the more you study it, I started to say, you realize there's something missing from your armamentarium and taking care of a patient. Look, I was a child basically at the time just coming into this, and I wanted to do the best I could for my patients. And I said, there are two areas, and I teach this, that need to always be looked at: the patient's individual biochemistry and certainly their physiology. If you don't know biochemistry or physiology, you will never be good in the integrative medical space. I don't care what degrees that person has, they just can't.
Right.
You have to know it so well. So when people say to me, oh, Mitch, what should I go read? I said, when you're on the toilet, read biochemistry and read your physiology over again. If you understand that, you can think out of the box. When you start looking at, and it's not important for this podcast, you look at how do we get the medicines we have, it's not a great story. And a lot of the stuff we have, especially today when we see what's happened with everything in the past 3-4 years, it's downright in some respects disgusting. So I have a real problem with it. And I realized that it was nice if we wanted to use if-then medicine. If-then medicine, if you have something, we're going to give you something for it. But they were telling us from the departments, from medical schools, what the if was. Like, for example, if you have high cholesterol, you should give a medicine. But really, cholesterol is put there for a reason, and that's a whole conversation in itself.
Right.
And then if you have this, you should do that. And with total disregard of whenever to take a medicine off, doctors never trained to remove a medicine, and total disregard for the most important part, which is your biochemistry, the glucolysis, your Krebs cycle, the electron transport system, without knowing that like the back of your hand, you have no idea what these drugs are doing. And there are things, for the most part, the body will correct on its own if it's given sort of the cement and the bricks. If you don't have it, then there's no way to repair the body or the cells. And so IV medicine's an important part. It's 100% absorbed with a minor deviation, which is extremely rare. If they have a nutrient transport system a problem, you wouldn't know it anyway. But for the most part, you have 100% absorption of most of the water soluble vitamins, etc. And whereas in probably the best day of your life, you're maybe absorbing 30-40% of an oral type of vitamin or mineral. And by the time you get to birth control and water pills, and you get to blood thinners and proton pump inhibitors, and it goes on and on, you might be getting 3 or 5%, let alone the fact that most women and men, by the time they're 50, have hypochlorhydria, exact opposite of this hyperchlorhydria that everyone seems to be put on a proton pump inhibitor or the old H2 blockers for. And there's things that we should know about what we should do. You can't get the nutrients when you're on that. It's impossible. You need acid in your stomach.
So very interested in what you brought up about, understanding as a medical provider, understanding biochemistry, right? I remember Dr. Willix, before he would actually get on stage at the AMMG or A4M. I remember the first time I went to go watch him, there was like a lot of people in the room, probably 1,000 people in the room. And he said, Sam, watch when I start how at least about 15 to 20 physicians are going to get out of their seat and walk out. So what the heck is Dr. Willix talking about? The first thing he started talking about was the Krebs cycle. Like a lot of these doctors that have already gone through school, they just don't want to listen to it. And me personally, I believe that the best doctors start off with the metabolic pathways. You see the Krebs cycle and all of the different gear wheels on there. But when you go into that whole biochemistry, the big chart, you know which one I'm talking about.
Mm-hmm.
If you're a physician who understands that, man, you can really reverse disease on a lot of patients, in my opinion.
Oh, no. It's not. Your opinion's 100% correct. When you look at the Krebs cycle, now there isn't a cell in the human body with the exception of the red blood cell, because the red blood cell has no mitochondria. They're the only group that doesn't. So with all the other cells, you're going to put the sugar eventually through, hopefully with the glycolysis, which makes a little bit of ATP, and we'll send it through to make 36 ATP net in the best of situations. It goes through oxphos and electron transport eventually, for the folks listening that understand biochemistry. The Krebs cycle, if you ever break it down, and I pretty much, whenever I teach IV, I always will bring a slide, the Krebs cycle. I said, I want you to see, if anyone ever says, oh, what's a vitamin, what's this? All you need to do is put up the Krebs cycle, because the Krebs cycle has no medication in it to make it go. It starts with a molecule of glucose, and it needs manganese, magnesium, essential fatty acids, it goes calcium, magnesium, it goes on. And I show the different areas in that cycle where these nutrients and substrates are needed. So without it, you're not going anywhere. Right. And you will not make the energy. Now, pretty much everyone knows today, and probably most of the people watching the podcast, and if you don't, you should, that pretty much everything, if it doesn't start off as, it will become a mitochondrial disorder.
Right.
End of discussion. So it will become that eventually. So if you go to the mitochondria, what is the mitochondria? Okay, so it's these powerhouses, the batteries of the cell for the lay people watching. They're anywhere from several hundred to thousands. The more active a part of a body is, like the heart, the kidneys, the liver, they require more mitochondria. And the end result is our exchange. And the exchange is the triphosphate bond known as adenosine triphosphate. And if you don't make enough, several things will happen. The person will become fatigued, etc. To the end result, which is where I teach currently, which is if there's not enough made, that body will apoptose that cell, it will exit out and kill it, or it will allow it to hijack and begin using the Warburg effect, since every single cancer cell does, and that is using lack of oxygen to produce lactate, which eventually, if you remove a proton, you'll get lactic acid. But that's so important. But here, using the nutrients, we're capable and able to maintaining a lot of that long before it becomes a problem. So don't know the Krebs cycle, you don't know really how to treat that patient.
Yeah. And you know, most of those nutrients, you'll see it there. And you know what I always have found very strange is a lot of physicians or nurse practitioners or PAs in the allopathic conventional medicine, when you start telling them about vitamins, minerals, amino acids, and the importance of it, they totally just trash it. Oh, that none of that stuff works. And I just started thinking to myself, I remember when I first got into the IV therapy space, I started thinking to myself, you know, looking at the protocols that you're teaching us with, and I'm just like, these are a lot of the stuff we use at the fire department for emergency medicine. Sodium bicarbonate, magnesium, we use potassium, calcium, you know, like we're saving people's lives, you know, utilizing nutrients.
Sure.
Even though people are looking at it, people in emergency medicine said they're looking at it as a drug, right? Because it's in sterile form and it can be injected. But these are nutrients that your body runs off of. You know, I correct a cardiac dysrhythmia with nutrients.
Of course.
So what is it that you can say to the people that are listening, right? That basically downplay the importance of nutrients.
Oh, it's very simple. First of all, you know, ignorance is ignorance. You know, you have to realize first of all where they're coming from. When years ago, and this is true, many doctors in the community thought, "Hey, Mitch Ghen, you're crazy." I was giving, let's say, for example, bacteria that people are swallowing, probiotics. Who doesn't give them? And of course, the Gastroenterology Association in the last couple of years focused on the microbiome. So all of a sudden it changed. Many of these doctors ended up my patients over the years. Many of them also came and said, you know what, I'd like to learn this, and they were starting to learn from me. Things have changed. Now, why did they change? Did they change because it was a monetary issue? I don't know. Maybe they just realized what they were doing didn't work. And, you know, doing podcasts and talking to a lot of doctors, you know, if you ask them, what are the things that you can cure? That's my first question. Well, okay, let's have an honest intellectual discussion. I have no problem. Tell me what you create, what you cure. Let's start with metastatic cancer. Oh, no, that's only palliative. Okay. What about severe coronary artery disease? Well, we'll put stent in it. I said, yes, keep going. Well, they'll eventually fail. What about heart failure? Same thing. And we go right down the line. Autoimmune disease, eventually, you know, it's renal dysfunction and failure, and every disease simply has its final common pathway. So I said, look, you say nothing or you believe that the nutrients don't have a place. Well, let me show you first the place. And that's when I opened the Krebs cycle. And so let me show you that all that you learned in your second day or second week, neither medical school or NP, PA school, whatever you want to, dental school, that was there. But it's pushed aside because your education is being sort of driven by another force. And you know what I'm saying. So you're being moved to that if-then.
The Rockefellers.
Right. You're moving to an if-then conversation. Look, that Flexner report that the Rockefellers had done got rid of pretty much the natural medicine in this country, homeopathy, everything was pretty much wiped out. Not only was it wiped out, but they prosecuted doctors back then. It's a pretty good thing when you want to have a monopoly.
Right.
Sorry, but that's what happened. You know, and then it's not easy when you go to a school and you spend a fortune of money, and every day you sit for 8 hours, and you hear this is the disease, here's the pathophysiology, here's the anatomy, here are the drugs, and here's the surgery. That's all you know.
Wow.
And you become sort of egocentric to it. And then comes along someone who says, by the way, do you know that vitamin C could have, or did you know that B complex or magnesium? It's like, there's no way. The truth is, I have, and of course, across my career, have seen so many goodbye disorders, because that's basically what I see mainly. I get the most complicated cases where everyone's given up and waves their hand. It's just like someone comes in with an ache or pain. You're getting older. What do you want? You come in with a lack of energy. You got older. What do you want? Well, that's not an answer. I always say there's no such thing as a normal symptom. There isn't. There's something going on. And the point is, can we do something about it? In the majority of the cases, we can if we'll guide ourselves and use all the things that are available to ourselves. And IV, of course, nutritional repletion is a major component. It's a major component of mine because I know I can get to where I need to go much quicker when it comes to nutrition. Nutrition's one thing, Sam. Another is energy balance, that you have, like whether it's meditation, like Joe Dispenza does, which is excellent that you mentioned it. I think he does a great job. If you're looking at, for example, hormone balance is two cells need to talk to each other. That's how intercellular communication typically occurs. And there's something about psychosocial, which we call mind body. There's no question. The person who thinks they're bad or sick, they're sick. We alluded to earlier in our conversation. Well, all those 5 areas and some detox are all mutually inclusive. You can have perfect nutrition, but you tell everyone you don't feel good. You know those people, I don't feel that good.
Right.
You can have perfect mind, body, perfect nutrition, but your hormones are poor. You still feel lousy because you have no intercellular communication. So all these things must be looked at. They need to be examined. They need to be repleted as you start to fix it. And IV sits right in that area of several of those areas where you can help out and actually enhance the therapies that you're doing. No question. It's my firm belief, and of course, look, I'm in the space. I'm started the space that if you don't use IV nutrition, you might still get to where you want to go with oral, maybe, but a lot less, a lot longer. But you're very much making a huge mistake by not addressing intravenous nutritional repletion because it is a center of much of the things we just mentioned.
Right. Doc, right now you see a lot of IV clinics popping up, a lot of retail IV clinics where they're not really doing what you're doing in treating very sick patients. They're doing it more for like wellness purposes. People come in, get the Myers cocktail. What is the difference between a physician really utilizing IV nutrition as a clinical treatment versus what you see all over the place right now, where it's more of, people go in and they're almost like picking off a smoothie menu type of deal?
Right. I hate that. And I think you know that already.
That's why I'm asking you.
I mean, you know what's going to come out of my mouth. I think it's the most, it's probably atrocious medicine in my opinion. And I always use the example. Let me ask you, would you go to, because you thought you had a lump, you go into the pharmacy and pick out some chemotherapy? Would you do that for cardiac medicines? Would you do that for anything else? It's so ridiculous, nonsensical. It really is sad to hear that. And to me, it's surely, it is not in a space that I would ever want to occupy. There is a right way and a wrong way. Look, no one has to be, or very few can be in the space. I take very complicated cases. It's not for everyone. Right. It's not. Not everyone has either the capability, the understanding, or want to be in that space. I don't blame them. And then the other end is, you just walk in and pick out something. You hardly have even a practitioner there. Sometimes you do. Some places, as you know, don't.
Right.
It's a serious thing. I don't think an IV should ever be given to anyone without at least doing some minimal amount of biochemical assay.
Right.
I don't, because I can sit here all night. We could talk the rest of ourselves out on all the possibilities and problems that can occur. And I'm sure you might have some of those questions for me. But I don't think it's right to start something, because at the end of the day, the whole thing about IV, goes back to our Hippocratic Oath. You do no harm. You're out to help the patient. If you're doing something and you can't clearly tell me 2 things, A, that what you did was safe, and B, that there's efficacy to what you do, why are you doing it?
Right.
Now, if I do something, I give something to a patient, I used to say this, I don't, because it's too cocky and it doesn't sound good, so I stopped it. I used to say to a patient, by the way, if you ever, when I give you your protocol today, you come back 6 months, I'll tell you the same thing, because I won't recall what I said, but you're going to hear the same reason. But that's true to a large degree. If you can't have a reason that shows that this is for efficacy for this patient, I mean, it's one thing if you want to you're giving someone some hydration, you think they're dehydrated. it's maybe that's out of this. But once you start mixing materials together, once you're trying to fix something or you're trying to you have a goal in mind. So how did you get to that goal? What history, what physical, and what at least minimal biochemistry led you to what you put in that bag and gave that patient?
Let's talk about that, because I
Sure.
think it's important for medical providers to understand some of the basics, when it comes to the diagnostics that you should utilize when you're assessing your patient to treat
Sure.
with some of these IV nutrition therapies. What does that look like?
Well, for me, it's a very comprehensive look. You know, I use the example. I like analogies. I think people understand analogies very well. So the very first thing I say is, look, years ago, you're much younger than me, but years ago, you may recall, you took a car in. They looked under the hood. They looked at the air filter. They changed the oil filter. They oil and lubed your car. They didn't see anything. They checked the carburetor. Bye-bye. What happens now? You take your car in. They hook it up to 150 check. So you should be hooked up to 155 check. The more comprehensive, the more in depth without becoming ridiculous, you're going to find out more about that person. Now, I do a very in-depth look because of the type of patient that I get, but the more I look, the more I know how to adjust that IV and whatever other program, whatever I'm using, oral or not. So I tend to give the example. Let's see if I could do this example for you, like I did in front of a group, how different we are. I spoke in front of a group about 4 months ago, about 400 people, and I said, is there anyone in here tonight that's going on a plane for the vacation this summer? A bunch of people raised their hand. I said, great. I said, I tell you what, I have great news for you. And they're just looking. I said, I've been watching a lot of podcasts. I've been watching a lot of YouTube and things of this nature on mechanics of a plane, how to fix a plane. And I actually read 5 reference books on it. So you don't need anyone to fix your plane. If you call me, I'll go out and I'll check the plane for you. And everyone starts to smile and laugh. I said, listen to that. You laughed, and you should. There's 1 million parts to a plane, average, million. The human being has probably somewhere around 868 trillion chemical reactions, give or take, per second.
Wow.
So as ridiculous as that is, how could I call myself a biohacker mechanic of an airplane? And so you're listening to this person over here and this person over here and this person over here. You're trying everything, and you make a milkshake and you think that's the right thing to do. It doesn't make sense. Let me take it a little further, I tell them. You have 37, give or take, trillion cells. Depends who you read. Let's call it 37 trillion. Of the 37 trillion cells, we have trillions of faults or problems to single-stranded DNA every day. The body typically 99.9% of the time fixes it. But we have 1 to 10 per cell double-stranded attacks, which is 100 trillion approximately to the double-stranded DNA. So you're literally, any one of them could turn into a cancer.
Wow.
So if you're not maintaining nutrition and perfect everything across the day, you can use all your words that you like. I eat clean. I never know what that meant, Sam. I think it means that you sterilize or eat. I don't know.
You wash the food under the sink.
You wash it. That's what it is. You eat clean. You do this and all that. And so, hence what I do is to be able to make sense to the patient. I do about 130 tests. Now, the minimum for IV, before you even do a little bit, should at least be a complete blood count, a CBC, and a metabolic profile. You don't want to hurt anyone's kidneys. You don't want to hurt anybody's liver.
Right.
You don't want to dilute them if they're anemic. There's simple things that you could do, minimum, to do that. Now, I go well beyond that. I look at inflammatory markers. I want to see as much of someone's biochemistry as I can. So I'm looking at the hormones. I'm looking at the inflammatory markers. I'm looking at nutrients. I'm really in pretty much every category because I can get a smattering enough to look at this with that and some physiologic tests that I do to give me a hint of, Mitch, this person would do good in this. Or, no, Mitch, go further into their biochemistry.
Right.
So, yeah.
Well, not just for the safety or even the course of treatment portion of it, but getting that baseline, right? Running all of those biomarkers, how you just mentioned, is what you're doing working? And do you have to adjust it mid treatment, when you're 2, 3 weeks, 4, 5 weeks in, how do you know? You can only know if you have that baseline in doing those
Exactly.
diagnostics.
You need a benchmark.
Right.
And
Yeah.
these are my benchmarks. And like I said, always teach biochemistry, physiology. So in my case, I'm always looking at the autonomic nervous system because pretty much 9 out of 10 diseases either initiated them or completed it in the autonomic nervous system. The only thing it doesn't is trauma because it's immediate. There's no time for regulation. I mean, everything from cardiac, nervous system, all are intimately involved in the autonomic nervous system. So if you have both ends of the spectrum, physiology, biochemistry, you have your history, you've done a good physical, I think you're as prepared as you could possibly be. Will we know more when you and I are long gone and our great grandkids are here? Of course, they'll know a lot more.
Right.
But you have to work with what you have. You have to do, in my opinion, you have to do the very best you possibly can for these individuals, for these patients that are, coming to us. They're looking to us. They expect us. They don't know what else to go to, and that's important. So I think skimping in that area is the wrong thing to do. I've told Sam many patients, "Oh, I don't want to do that. I don't want to do this." I said, "Okay, it's no problem." They said, "Really?" I said, "Yes. I know there's other doctors. I'll push someone away.
Yeah.
I don't need another patient." I said, "I'm here to help you. I'm going to help you any way you want. But if you want to tie my hands, then to be quite frank, I can't help you. How can I help you?
Yeah.
You don't want to do this. You don't want to do that. I'm sorry. I'm not going to give you an IV just like that."
Yeah, I think that's important, and you're starting to see that in a lot of different healthcare settings. That even with chiropractic, right? You got all of these facilities, these franchises opening up the joint. I'll just say how it is. They're not doing any X-rays. They're not touching. You just go in with back pain, and they just go ahead and adjust you.
Okay.
And for me, it's just like, man, you don't even know what's going on with this person. If they just had some kind of injury, an accident, like you can make that situation a lot worse. So I agree. Baseline, getting that baseline and doing some diagnostics is very important. Dr. Mitch, I want to debunk a few things on this podcast as well. So I'm going to you as the guru. This is a true or false, and then you can elaborate a little bit on your answer. True or false? Are you able to do a precision vitamin IV therapy IV based off of epigenetic testing only?
No.
Okay.
Oh, yeah, I know you didn't finish, but I answered it already. And I can elaborate for 2 seconds if you want. The epigenome for the folks watching is pretty much the environment in which the genome sits. Everyone has single nucleotide polymorphisms, every single person. And yes, it will change the way we do. But the epigenome controls that genome. The genome itself may never do anything specifically as far as reproducing itself or not doing something. So knowing the epigenome, and yes, and you could do, there are tests that sometimes that can look at the epigenome and see, where it's at. But so you might do things that maybe stabilize it, but it is not enough to know what IV to do. The best way to stabilize the epigenome is do the meditation that you were talking about earlier with Joe Dispenza. It actually changes the gene expressions significantly in literally an hour or less of just thinking and making things happen the way you want to.
I use the brain tap, Dr. Porter's brain tap. It works very well for me. But so this is one thing that I got into a little bit of a debate, in the industry where people are creating these so-called precision IVs based off of an epigenetic test, and I'm thinking to myself, it's like, you're not even going to do like a micronutrients test to even see what nutrients are actually going into the cell or what the body's actually lacking. Like, how are you doing a precision IV just based off of the epigenetic test?
You can't. But it's a good gimmick, don't you think? Look, there are so many gimmicks out there. I've been around so long. I know every new nuance that's come in. And I'm sure there'll be more that will bypass me. But for sure, knowing and doing and looking at the epigenome itself, there is absolutely no way you can tell what's happening and what IV you're going to give that person. Now, you can use an algorithm of your choice. The company that's doing the testing, I'm sure, are the ones pushing it. The companies that do it probably can make an algorithm that this nutrient is best in here and here. It just doesn't work. And I hate to tell you, neither does micronutrient testing work at all, in my opinion.
How would, okay, so this is where the question is going now. How would you, as Dr. Mitch Ghen, create a precision IV? What would you utilize? What data points to create that precision IV?
Yeah, that's a great question, mate. Number one, it's my huge comprehensive biochemistry that I did and the physiology functioning that I find. That's how I create all the data points. They're real, they're reproducible. There's something I can watch. I can look at it again and again. Like you said, I can go back. I can look at these benchmarks. The epigenome may or may not change. It may or may not change. You're not going to change someone's. They do these genetic modeling too. Makes me laugh too. I used to teach it, but there's not much I can do as far as. I give you a perfect example. I have lots of patients that will come in. The same. Oh, I have an MTHFR problem.
Right.
Well, so I usually first thing I'll say is it heterozygous or is it homozygous? They don't know what I'm talking about. It doesn't matter. Well, I have this. So then I explain to them, look, first you should be aware there's nothing wrong with using methylated Bs and to begin with, and methylated folic acid anyway. I only use it anyway. But here's the thing. A gene does not have to express itself. You can have a SNP or you can do these gene testing that suggest you have the loss of the MTHFR or you have the MTHFR and means that you won't methylate properly. But it doesn't mean it's going to actually express itself. So they said, what do you do? I said, very simple. I never do the test. Well, how do you know then? I said, simple. I watch the homocysteine and I track it over time because I know the entire pathway of the biochemistry of it. I know the homocysteine will start to rise. If it's not that, then it's the level below it that's a problem. But the key is if the homocysteine is fairly within normal range, it's not going to be outrageous. And I've seen this lots of time. I've gotten patients from the University of Miami. A kid had 180 homocysteine. That's insane when 6.5 around is normal. And we brought it down to normal. Took us about 3 months. I got it down to normal for him.
Methylfolate was kind of the primary nutrients you were given to bring that down, or
what's that?
Methylfolate?
I use methylfolate. I use B2, B6, the things that belong to that. I also accentuated the secondary pathway to have methyl donors occur. I use that as well. I made sure they didn't have a sulfate deficiency or one of the other deficiencies in the pathway. And I just slowly, because sometimes when you do things too fast, another problem with these clinics that like to jam things in, we can get to that, makes a huge difference, huge difference. And he's back to normal, to a young fella, back to work, doing well. And but that's the kind of thing that I'm always concerned about. I want to know what's actually happening in real time that I can affect. You want to affect, it doesn't matter. You can even have a BRCA gene, which of course, depending on what you read, it goes from 32 to 85% that woman or male will have a breast cancer, ovarian, or something of that nature. And the truth is, there is a percentage that don't. The worst of all of them is an I can't remember the total one, gene dislocation, which actually 99% they'll have colon cancer.
Oh, wow.
So there are a few of them. So I always say, why do you get this? And when I talk to doctors or healthcare practitioners, why are you getting these things? What are you going to do about it? Oh, then you're going to send them for a genetic, talk to a geneticist? How's that going to help? That's not going to make anyone feel bad knowing they have a 45 or 50% increase in pancreatic carcinoma, or you have a marked increase in colon, or you have an increase in breast. What are you going to do about it? Well, at that point, yeah, I'd think about stabilizing the epigenome. That's important. But the best way to stabilize it is by giving the nutrients that it requires, the IV, and that can be specified, as well as then you're doing meditation and other things along with it. That's what you do. You prevent the cells from going bad, basically. It all comes down at the end of the day to cellular medicine.
Cellular medicine. So guys, you heard it from Dr. Mitch Ghen. You cannot create a precision IV based off of epigenetic testing. And not even the micronutrients test. These are good tools to use as a guide as you're treating your patients and get that baseline. But the stuff that we're seeing out there, it's a gimmick. There you go. I wanted to get that out of you, and I appreciate that. Dr. Ghen, when it comes to IV therapy, going back to a lot of these clinics just offering these IV drips out there, I want to go to the basics. I want to start talking about the solution that's being given to these patients because you got some clinics out there that'll use lactated ringers, other are utilizing only normal saline. I've seen people give high dose vitamin C and normal saline where this is like a crazy hypertonic solution. Let's bring it down to the IV therapy 101 here.
Okay.
Hypertonic solution versus hypotonic solution.
Okay. So the first thing we need to go is to go back to biology 101. When you were a kid, probably high school biology, you realize that fluid will tend to move on its own to where the greatest solute is, where the most material is. So if you think of the red blood cell, for example, and you think of the space next to it where the fluid's going and where there's fluid, fluid will move where there's the most amount of solid material. It's the best way to think of it. So if there's the most amount of material in the red blood cell, then the water will go in. What will happen? The red cell will blow up and eventually break. The opposite is there is less in this area and more of solute in this, and the cell will begin to squash, which we call crenation, and will give up its fluid to the outside. Now, which is safe? Neither, but there is a but. The hypotonicity is the most dangerous. The hypotonic solution is the one that will go to where the most solute is, blow up the red blood cell, and cause hemolysis. That person can have a hemolytic anemia. The other one, if it's given slow enough, you probably can get away with pretty high hypertonicity solutions where the osmolarity is quite high. Now, normal osmolarity, I'll call 310 is normal saline, and you probably the closer you could get, the better. But typical solutions I give are probably 800, 900, 1,000. I have in the past. I don't typically anymore. I've given 16, 17, 1,800, but it's the time. The body does regulate to hypertonicity much better than hypotonicity. So if you go slow enough, which you should do anyway, then the body will accommodate that type of fluid. If you don't, then you expect what's going to come from having fluid overload and, shortness of breath, chest pain, headaches, and everything else that goes along with these side effects. So when you're talking about osmolarity, there's no question, whatever you're going to put into someone, you better be aware of it and what you're doing. Because not only you're shifting solute, you could be shifting electrolytes too and cause an electrolyte imbalance simultaneously as well.
Right.
So you have to be very cautious with doing that. That's 101 answer to using it. There's more to it. There's no question higher concentrations of, let's say, vitamin C will go into a cell better than lower concentrations because there's the gradient to make that happen. But in general, from the safety perspective, you want to make sure that you're not causing massive fluid shifts in someone because the body that's not young, supple, ready, liver damage or kidney issues is not going to tolerate it that well. And then you run into issues. Maybe not while they're in your clinic, but later on.
Right.
And you may not even know about the problem. But it should always be, as we said, it should be a safe way of giving it.
Doug, would it be safe to say that any providers that are looking to offer high dose vitamin C to their patients, they should really consider not just using normal saline, but utilizing sterile water and other type of fluids, correct?
Yeah, I'm sorry. I absolutely. If you're going to use high dose, if you know the osmolarity, it's look, you never give sterile water. You don't see sterile water in the hospital. You didn't use it when you were a paramedic. No one gives it. It's too hypertonic and it will cause problems. However, the minute you move material into that sterile water, you're changing the tonicity instantly. There are only two things that change tonicity fairly regularly because each individual item has its own sort of set osmolarity. Vitamin C is the one. Magnesium is some, but you never can't use that many, 4, 5, 6 cc's. But vitamin C you're using a lot, and the liquid. So if you want to raise the tonicity of a solution, you either drop the fluid or you can add more salt, so or more sodium ascorbate as vitamin C. If you wanted to lower it, you either add more fluid or you lower this. That's really the key to maintaining it. So using sterile water is a fine thing as long as the practitioner who's ordered that is quite aware of what am I dealing with and how much it is. I normally, when I teach one thing to keep in their mind, a simple one I call a mini. I trained you on it. And from that, if you know the tonicity of the mini, you know how much vitamin C is in there. So you know very quickly, if any other IV, what you're doing to it, and you know how to adjust it.
Yeah.
Yeah. I mean, no one sits in and runs it on each one, but you have to have a very good sense of where you're at and what you're doing, because it's not only that tonicity, but you also run issues with the material you're giving. Vitamin C is the mainstay of a lot of the nutritional. People are not aware, perhaps, that there's 64 milliequivalents of salt for every cc, for every 500 milligrams. You give, 100, you're giving 100 times 64. So you're giving 6,400 milliequivalents of salt. That's like eating at a fast food store
Right.
3 days in a row of French fries with salt all over them. And there's certain people that have no problem with it, and they're elderly that you can put into heart failure from it.
Right. Is that from the hypernatremia from it?
Yeah, you can cause hypernatremia because vitamin C is a salt base.
Yeah. I have your osmolarity calculator that you developed, and I still use it till this
I
day.
see. There you go.
Whatever. So, which if you're comfortable with it, I could share it as a link on this podcast.
Ah, of course. Yeah.
So, all right. So we're talking about high dose vitamin C. What is high dose vitamin C? And the reason why I ask that is in the industry, some people say, oh, well, 10 grams is high dose vitamin C. Oh, no, 50 grams is high dose vitamin C. What is high dose vitamin C?
Well, we go back to the basics. Vitamin C is actually a twin edge. You have to be aware of it. It either is an antioxidant. All vitamins are antioxidant at most levels. Pretty much every vitamin name, it's an antioxidant of some sort. By definition, meaning it's willing to give up an electron from its outer field to pretty much stabilize a free radical, which has only one electron in the outer field. Okay, so that's the basis of free radical medicine. But so vitamin C is an antioxidant by definition. At some level, vitamin C is going to become oxidative. Now, what are you trying to do should be the question, because it again goes back to what I said. What's the purpose of what you're doing? So for me, if I'm treating, for example, a cancer patient, I want oxidative doses. I want to reduce the glutathione intracellularly, which high dose vitamin C does. I want to create hydrogen peroxide, which the cancer cells do not have catalase, and where the good cells do, and it will disperse it and make it, into water, etc. So the answer to it is not that easy, but I will tell you. If you look at vitamin C, to get to levels that are basically tumoricidal, which are oxidative levels, it's somewhere between 1 and 10 micromoles per milliliter. What does that mean? So you're looking for somewhere anything after 5 to 10,000 milligrams. It starts to become oxidative. There's a caveat to this thing. But for sure, if I want to be sure, I'm going to be above 50,000. Now in cancer, I use 1.5 milligrams per kilo. So I'll be in the 7,500. I know I'm oxidative because I want to maintain the oxidative levels. And I know that if I give 100,000, just for example, I know for the most part, I'm going to be running, I told you 1 to 10 micromoles per milliliter. I'm going to be at 24, 25, 26, 27. I know I'm going to maintain that if I give it quite slow, which is the only way to give an IV, that for the 4 hours that I give it, or 4.5 hours, I'm way in that. And I know that when I turn it off, because I use so much at the degradation rate, which is about 2.5 hours for vitamin C, that in 8 hours, I then will start to be below. So for 12 hours, I'm in that tumoricidal event. For those that don't know, vitamin C orally can never reach tumoricidal events, cannot be cytotoxic. So I'm trying to run the range in that. So if you're trying to, for example, you want to try to be antiviral, for example, then anything around 20 to 50,000, I find that range to be oxidative enough to be antiviral, at the same time to be immunologically stimulating. I want to be oxidative Like for certain cancers, specifically like sarcomas, need a lot of oxidation. Then I'll use much, much higher levels and I'll go that 1.5, and then you're on the other side. So again, it depends. I told you there were some caveats to it. There always is.
So if you had to, and I hate putting you on the spot like this.
That's all right.
But I know what a lot of the viewers and listeners are probably thinking. If you were to have to pick a specific number, grams or milligrams for ascorbic acid for the vitamin C, for it to be considered high dose vitamin C, what would that number be?
More than 50 grams.
More than 50 grams.
50,000 milligrams or more.
So now when we start talking about, someone getting high dose vitamin C should get a G6PD test. Are you running the G6PD test 50 grams and above, or are you doing it also for the person getting 20 grams or 25
I do it
grams?
before I give them an IV of vitamin C.
Okay.
Now, here's the deal. For the most part, look, the Ashkenazic Jewish population does have that problem. The Mediterranean people do. 10% of the American black male population also has G6PD. So
what happens with that? Just so the people
okay,
don't
so
understand.
if you have that deficiency, you're not able to degrade vitamin C well enough. And what happens is you can actually bleed. It was known originally as favaism, if eating fava beans or broad beans. People in the Mediterranean found that when they ate this, they would bleed. You could actually cause someone everything you don't want, meaning they can take it. If they have a G6PD, they go to the bathroom and they can literally urinate and bleed the whole toilet up.
Right.
You don't want that. So getting a G6PD, for me, really regulates how much I can give to that person. Now, normally you can give a little bit. Orally, it's extremely hard to cause hemolysis and cause RBC breakage. But when I'm using doses that I'm using, I wouldn't dare give it to someone without having a G6PD
Right.
in my chart to prove it, and I put it in my notes and so forth. If you're around 5,000 milligrams, they say even up to 40,000, and some studies that I've read in the past are okay. I would not recommend physicians that are watching this to do it at 40,000. I would recommend if you're going to see a patient, you're going to use IV nutrition, you're going to use intravenous, and get a G6PD.
Should be part of your baseline.
It's a baseline test. It's a bottom line test. It tells you a lot. And now I have a patient now who has cancer who had a very low G6PD. I said, okay, we use something else. I didn't use that. And by the way, for those of you out there that are doing methylene blue, be careful because G6PD deficiency will also cause that person to bleed too. If you're using intravenous methylene blue, you better have a G6PD in your chart.
Yeah, I heard even ozone and EBO2.
Oh, yes. Oh, yes. If you don't have a G6PD, there's these things are not tolerable for these people at certain levels. And everyone's different. What 5, 10,000 will do to one, it may do it at 5 to another, or 30 or 40 to another. You don't know, but why would you take a chance? It's all about what I said, safety and efficacy. Why would I compromise that many patients? It doesn't make any sense. The point is, you have to have the capacity, like we said, I'm going to tie it back to what we said earlier. You have to have the concept of the physiology and the biochemistry so you know how to build a bridge 5 different ways. Right. So if the first bridge you can't use another one, build another one. That's the big key to all this.
Now, Dr. Mitch, I remember you telling me before when it comes to, we're talking about high dose vitamin C, and you were telling me about how patients, when you're giving, let's say just 25 grams, 50 mLs of this vitamin C, and sometimes you're going quadruple that, with some of these patients. The importance of utilizing preservative-free ascorbic acid. I want to talk about the importance of preservative-free nutrients, especially when you're going to these high doses. And I know the typical preservative is benzoyl alcohol, which we all know that benzoyl alcohol is a known toxin, if you will, right?
It
can cause oxidative stress, can cause inflammation, which kind of really makes me think that's kind of counterproductive of what we're trying to achieve, right?
Yeah, you think? Well, first of all, let's go back to why someone would even use a preservative one. There's a couple reasons. One, certain elements, the smaller ones come, the ones that you use less of, they come with benzoyl alcohol. Benzoyl alcohol typically is 9 milligrams per cc. To give you an idea, once you get close to 1,000, milligrams, you're in a big toxic troublemaker.
Tell me more about them.
Yeah, so 9 milligrams pretty much per cc. 1,000 milligrams, you're already toxic. Babies even less, by the way. The point is, why would you want to put a toxic material regardless, even if you're using a lesser amount? If someone can answer that, then okay, I'll listen if they give me an academic answer. The other problem is, like if you use preservative vitamin C, you have 9 milligrams per. Let's say you're using 100 cc's, and you have 100 cc's for 50,000. You're doing 50,000. Well, 100 times 9 is 900 milligrams right from that alone. You're on the edge of this being toxic. So how in the world are you creating improved cellular activity? Now, I understand why most do it. The reason that most do it, and I'm going to say something, and then I hope I don't offend any of the others out there, but the reason they do it is because once you stick a bottle with a needle, it's a single-use bottle. There's no preservative. You need to use that bottle up in that day.
Right.
So for those that need to stick the bottle several times and up to 30 days once you stick it with benzyl alcohol in it, you can use it over and over again for IVs. The problem is if you can't use the single vial, you can't use enough. Ask the compounding pharmacist to make you smaller vials instead of 30 or 50 cc's, number one. And number two, if you can't use the smaller, don't want to pay for that, then don't be in the space.
Right.
I mean, I tell people, okay, it's here, I'll tell you what, I'll put benzyl alcohol in a cup. And here, I'll just give you the 1,000 ml to have a drink. And there's not a doctor watching that would say, what are you, nuts?
Right. But you're okay putting it in the vein.
But you can put it in someone's vein.
Right.
It reminds me of such ridiculous stories. Can I tell you a funny story? Okay.
Yeah.
My brother-in-law at one time, because it reminds me of this. He's a dentist, and he graduated first in his class. At one point, it's years ago, he said, Mitch, I need to fix this tooth and you have a cavity, drill it. I'm going to put, what are you going to put in? I'm going to put amalgam in. I said, you are not putting mercury in my tooth. He says, Mitch, the ADA says, yeah, it's the right thing to do. I said, really? I said, okay. I want you to explain me one thing and then do one thing for me and then fill it with the amalgam. He said, okay, Mitch, what do you say? I said, explain to me how that amalgam's toxic when it comes out of the machine. You put it in my mouth, it becomes non-toxic. But when you take it out, OSHA suggests that you better take it out the way they say or you'll be fined $10,000 for the removal of that. How's it possible it goes from toxic, non-toxic for 15 years to toxic again? He's looking at me. I said, but that's only the first part. The other part is, I want you to take out the amalgam you're going to put in, take your glove off, put it in your hand, close your hand around it for 10 minutes. Because then you can put it in my mouth. He goes, but, well, Mitch, I can't because I said, what? It's toxic. Yes, now you get it. So you can't put it in my mouth. Do you know the next day he stopped, he read, I sent him papers to read. He never used it again.
Really?
Because, it just was logic. I said, you're going to listen to your association. I'm sure whatever the reasons, it's not for me to know. I don't know. But how are you going to do something that's so illogical? There's no logic to what you're suggesting to be done.
Yeah.
And that's what it is. Same thing in this case. Where is the logic of using a toxin? And it goes also to one other story that I will tell you. Oops, sorry. And that is the argument, it's only a little bit. That's what others will tell me.
Mm-hmm.
Now, I had that once. I was doing a talk show. I had my own show. It was in North Carolina at the time. And I was saying how there's toxin in apples and blah, blah, blah. And I want my kids eating organic. So I get a call from a farmer. Dr. Mitch, what you're saying is not right. I said, okay, talk to me, man. It's okay. We talking here. He said to me, that for me to be a grower and make a living, we use these toxins. It's only a little bit in each one. So I said, okay, man, I want you to listen to me. I have kids. My kids, they have found, studies show that if you have an apple a day, you usually have about 14 toxins in your system by the end of the year. I said, my children are young. Their livers are not capable of handling all this, but you want me to do a little bit so that you have your living. I got it. Oh, wait, what about the guy who makes the asparagus? Oh yeah, a little bit, it's okay. And what about this one, a little bit? I said, you know what? You could take your little bit, and of course it's radio, I won't say it, and you know where it can go. And I took them off. Great thing about radio is you can go click, goodbye. Guess what? I don't think he ever called me again. But it's the same thing. Why are we not doing the best thing for our patients?
Right.
If you can't afford it, then why be in the space?
Yeah.
And look for something else. And if you really want to do this, I tell people, you want to learn something, you don't put your foot in the water. We don't teach our kids on deck how to swim. We get them in the water. We get them used to it. We teach them how to put their face on, and we teach them to swim.
Right.
And when it comes to IV, I'm adamant, as you know, Sam, about you need to learn how to swim in this field.
Yeah.
You need to know these things. I mean, you don't have to know every nuance to it. Nobody does. I don't either, but I'm learning every day. And the point is, I live and breathe this. So, and you know, in my career, I've given hundreds of thousands of them personally. So
Right.
I want to know that I'm helping patients. I'm not hurting them.
Yeah, and you know the whole thing with the preservatives, it's been a sticking point for me because you know obviously we're partnered with NSAO Health and we've created a particular product with NSAO where everything from the glutathione, the B vitamins, from the ascorbic acid, it's all preservative free. Smaller vials, how you said.
That's what they do. That's
And
exactly.
just give the patient the best quality product, something that's
Absolutely.
not going to cause further issues, right?
You're spot on.
Yeah,
Continue in that direction.
yeah.
I'm proud of you.
Thank you. Thank you. So Dr. Ghen, you know, we're talking about toxins, right?
Sure.
And you know, we all know, especially with the big movement that's happening right now, Make America Healthy Again, about all of the toxic chemicals in the foods, toxic chemicals in our environment. You know, there was a study that recently came out about there being toxins, microplastics inside of these IV bags.
Mhm.
Did you read about that?
Yes, I'm very aware of it.
So, study came out. How do we prevent those microplastics from going inside of our patient?
Okay, so we have two issues. The prime issue of the article is much a no issue. It's what I'm going to say secondary.
Okay.
Primarily, the microplastics that we're seeing, 95% of them are larger than a 0.22 micron filter. So you could put an inline micron filter, you know, the filter set where the stuff will drip through, and get 95% out.
Do you run all your IVs with that micron filter?
No, but some of my, well, I'll come back. The answer is no, because none of the IVs I use have, you know, they have no microplastics in them. You used to use glass. There are some. Braun makes a few that do not have any of those microplastics in it.
Okay.
So you don't have plastic. But anyway, so EV, the ethylene vinyl does not do that. It doesn't leach, but we'll come back to leaching.
Yeah, I know there's like the DEHP free.
Well,
and
that's the ones you want.
PVC free.
Yeah,
right.
because that's the plastics, the
Right.
the bisphenols. Okay. So so the problem is not that part. Here's the real problem.
Mm.
It's something called nanoplastics.
Ooh.
So for every ml that comes out of a bag that's like that, you have about 1,600 microplastics, which we could probably get off with the filter. But there are millions per ml of nanoplastics. And guess what? You can't get that with a filter. 0.22 micron can't get to it. There's not a small enough filter to grab them.
Wow.
Millions per ml. So it's the nano ones that are the problem. And of course, you have other things that will help. If you, for example, if you left your bags in the heat or in a heated room, they're going to leach more. Heat makes it leach much more. Anything that will change the pH, specifically more so towards the acidic side, what are we using? Vitamin C. So if you make a bag and keep it for several hours before you're giving it to the patient, you're doing them a disservice. You should make the bag as the person walks in and give it to them,
Right.
so that you're also reducing that potential. The more things you have in it, the more the chance of leaching. Or we try to find, which I used when I started. You may never have seen it. I don't think you probably saw it on the trucks, which was glass. Years ago, we used glass, but the glasses need a vent to the drip set, or you have to put a needle in to vent it, or nothing drips.
Right.
You know, it's pretty embarrassing.
Yeah, I've only seen the glass bottles when I've gone back to Dominican Republic.
Yeah, you're too young to see
Yeah.
it. But actually, it's the best because there's no leaching of anything.
Right.
It's you know, or you change the bags to the ones that don't leach. Now, do we know everything that's leached, even in those? And yeah, we don't. And again, it's always about a benefit risk. So let's go back to sort of put this conversation together a little bit. If you're just taking a substance and you already have the tonicity messed up, and then you put in vitamin C, and it's leaching, and it's warm, and it's, you know, and you use preservative benzoyl alcohol, you could be doing, and I did the extreme for a reason. you really could be doing a disservice and actually causing a lot more problems just because you don't see it at the time of the IV.
Right.
It doesn't mean that person's doing well. You help them. So all these things must be taken into consideration. They're good questions because these are things that, as infusion centers are, they need to address this. Do I believe the infusion centers that are like you pick out the milkshake, like you said earlier, or however you put it was great? No, I don't think so. And I think there's so much that's going on. It's a problem. I want to give you one other example. This just happened 2 weeks ago. I'm a consultant, as I told you, consultant for a very large, a nice cardiology group. And they had a nurse that was working for them. The nurse is taking her course and becoming a nurse practitioner. She has a friend that's a nurse practitioner who says, come on down. I don't know where it is. I'm not going to say even if I knew, but come on down. It was to the south of Boca. That's all I can say. On a weekend, let me give you an IV. Gives her an IV. I have no idea what. Actually uses a pressure cuff to put it in, puts ozone in it too, puts everything that I would consider you could do wrong. This Yahoo did wrong.
Wow.
And this is what happened. I got to meet the woman. She gets up after the IV, goes totally blind, and falls to the floor, has a CVA, stroke, and a heart attack all the same time. Ends up, of course, in intensive care. Thank God the woman made it. Her EKG looks like something you would go nuts if you were still in paramedic. Total inversion of all the T waves across the precordium and everything else. And basically is not the same. I don't think she'll ever be the same because they probably damaged so much tissue. By definition, MI and stroke are necrotic tissue. I mean, she's never going to be perfect. Only because the person who did it was A, in a hurry, B, never knew how to add mixture properly, probably didn't follow, the main USP 797, which is what we're regarded to follow as doing moderate level type of compounding work in giving IVs. And these are the things that will happen. Again, I can't emphasize enough. And I just got done teaching about 84 doctors last weekend in IV. And the emphasis at the very beginning of the lecture is, if you don't know how to do the safety and you don't want to take the time to learn what works, whatever, learn 1 or 2 IVs, use what I use. It's safe, and don't do anything else.
Yeah.
And because otherwise, what are you really doing? If this is about money, I probably can give you 10 other fields you can go into to make more money.
Right.
I mean, let's be honest.
Yeah.
But if you want to do something that's good, it will add some additional remuneration to your practice. It will, of course, really help people when you utilize it properly. If you want to be a headache institute after someone drinks too much at night and you want to just give them lactated ringers, okay, God bless you. That's your thing.
Right.
It isn't mine, but there's a whole gambit between this and me.
Right.
And just whatever, at least be safe.
So you were talking about some of the heat, making the bags leach off plastic and things of that nature. There's always been a bit of talk about the nutrients going in the bag being sensitive to the light, and people buy covers for it.
Yeah.
What's the 411 on that?
It's a great question, Sam. The vitamin C particularly degradates in the light. If you want to be a purist, you should probably use either a life-proof bag. You could even use tinfoil and put it around. The key is the same as I said earlier. If you choose not to do that, make the bag no sooner than when that person is there and in your clinic.
Right.
Don't make it sooner, because you do have 2 or 3 hours by, I think, USP 797, and then you have X amount of hours to give it. But all the things that we've talked about tonight are going to be occurring, which doesn't make any sense. And not only that, there's an economical perspective. If you make a bag and the person doesn't show, you think you're going to keep it overnight. If you do, you should be,
Right.
whipped, so to speak. So make it when someone comes in, even if you're not using, light sensitive bag. Usually, like in my office, it's dim. I don't have real high fluorescent bulb and UV light hitting it. I don't typically cover it, but if I feel it's being delayed, I will tell them to go ahead and cover it. Most of the time, it won't degrade that much, but vitamin C does degrade in light. So you want to get it started, make it, put it in. That's why it comes, when you see vitamin C, it comes in a real dark bottle. There's a
Right.
reason for it.
Right.
And but again, if you want to do it perfect, and I encourage everyone to do it perfect, either buy light-proof IV bags, which you can put over it, or just get tinfoil, cover it in tinfoil.
Right.
But you want to be able to have what's in that bag to be seen by any nurse and anyone who walks by immediately. So if you're going to use tinfoil, you'll have to use some other, tape measurement that you can tell what's in that bag
Right.
instantly.
So, Doc, earlier you mentioned about the woohoo nurse practitioner that made the lady go blind, and one of the things that people bring up in the industry is, oh, these are just water soluble vitamins. If you have too much of these vitamins, you'll just pee it out, right? But as we know, and I've learned from you, there's certain nutrients, right, minerals that if you give a patient too much of, it can cause things like irreversible hearing loss, right? So I want to touch up on that about some nutrients that you can really harm the patient if you give too much of.
Well, let's go back to the base. Theoretically, Sam, and too much of anything definitely could kill you.
Right.
That hypotonic water, hang a bag of sterile water. I'll count 1 hour, the patient will be gone. They'll have severe hemolysis. So any nutrient in any inappropriate dose could cause a problem. The one you were suggesting and talking about was the zinc. There have been studies that show that more than 10 milligrams of zinc should never be given in any single IV because of the fact that there is irreversible unilateral hearing loss that's been seen in the literature. You name the mineral, you could do it with any one of them. That you give, if you give too much, you give too much magnesium, you'll call it hypermagnesia. You better have an EKG and have someone like you around that knows.
Potassium, lethal injection, right?
Of course, all of these things
Right.
become. There isn't. I guess I want to make it clear to the audience that's watching, especially the physicians, healthcare practitioners that are watching the show, and certainly we appreciate your being here. You have a great show. You have a great way with you, and by the way, I should say that.
Thank you.
I think it's wonderful. But anything can become a problem.
Right.
That's why it has to be adjusted for that individual, and that's really the case. So any nutrient could become. I mean, even too much B12 could actually become an issue with if you give too much of that I mean, you name it. You could give too much of any of them, which can cause a significant problem side effect.
Right. Right. Thank you for that, Doc. Doc, so let's go into glutathione, the master antioxidant. Who should get glutathione? Who shouldn't get glutathione? I've heard things about asthmatic patients, patients with sulfur allergies. Glutathione. Let's talk
Great.
about
It is the number one intracellular antioxidant. So you're asking me who should and who should not get it. Okay, so you're right. If they have a sulfur allergy, it's made by recombinant DNA, but a sulfur allergy can be an issue, and you should be very cautious in giving it with someone with sulfur, as you should be, by the way, since we're mentioning mag sulfate. Mag chloride, no, but mag sulfate, yes. If they have an allergy, they can have a serious anaphylactic reaction to mag sulfate. So with that being said, if they have an allergy to it, it's something that you should pull off. If I'm treating a cancer patient, in most of the time with high dose vitamin C robs glutathione so that cancer cell can't live. Why would I be giving glutathione back again? So I don't use it for that. The other extreme is why give it glutathione? Well, as you get older, you're not producing as much. It is an important intracellular antioxidant. It does fit into the cascade. And going back to the earlier discussion, when you look at free radical chemistry, every time you take a molecule off of a antioxidant, like we're talking about vitamin C, it becomes a free radical. So it has to be paired with E. And again, E will give up a molecule, but then it becomes a free radical. And then you have alpha lipoic, and that gives up, and that will make, and alpha lipoic is good because it's both sides of the cell membrane, so to speak. And then you have glutathione. So you want to try to stack the antioxidants enough so that you're stabilizing. The whole key is to stabilize the cell. That's why sometimes we use taurine, because it's a very good cell membrane stabilizer and that kind of thing too. Anyone that's sensitive, someone who has poor liver function, you have to be very careful not to give the glutathione any large dose. They can't process it fast enough.
Right.
I've done it, been there, done it. You asked me a problem, I unfortunately have had it.
You learn from experience.
I mean, after hundreds of thousands, you've run into everything. I at least could say I was able to correct all the issues. But they're, God forbid, if you can't, then what? If you don't train properly. So the glutathione in someone, for example, who has liver dysfunction or has cirrhosis, you can't give them 1,000 or 2,000 milligrams. They don't tolerate. You have to start maybe 400
Wow.
milligrams
Right.
to start with these people. And like I said, when you're trying to reposition the cells to be healthy, especially in the wellness market, which many people are in that space, and you want to keep people healthy, you want to keep the levels of glutathione at respectable levels. You want to make sure you have antioxidants. So the question, which I know is coming from your mouth, so I'm going to answer it. Well, how do you know you have good antioxidant status? Well, you look at those parameters. Like, for example, I do MDA by T-bars, which is basically the gold standard malondialdehyde of the urine. It looks for lipid peroxidation. I like getting often 8-hydroxy-D-guanosine because it looks at 8 DNA adducts and DNA damage. But if you have too much MDA as well, it will create a peroxynitrate, the OONO free radical itself, that can cause damage. I look at hemoglobin A1C, not just because, oh, is there sugar in control, because it is a very clear indication of protein choking the red blood cell. It's the sugar rather choking the red blood cell. So that's how I know. And that's how I monitor. You asked earlier, how do I monitor? Those are some of the ways I definitely monitor. Do I give enough? Did I give too much? Did I change anything? And that's the way to fly.
Right. Right. Now with glutathione, some patients tend to have that flush feeling and
They do.
have that reaction. So I want to talk about the difference between a Herxheimer reaction versus potential endotoxin shock.
Oh,
Right.
wow. You're going to go down there. Okay.
Yeah, it's important because obviously in the years that we've been doing it, especially when we first started, right, where a lot of these 503A pharmacies were just kind of producing stuff on the fly. There was times that we received bad product that the patients were going into endotoxin shock, having the full blown cotton fever. And I remember reaching out to you. I was like, Doc, something ain't right. We're doing everything exactly how we've been trained, and something's just not right. These patients are leaving and having, so. But then as you start growing and you're working with a lot of patients with toxin issues, right? And you're doing even something as simple, forget about the IVs, doing some of the stuff that Chris Shades does with Quicksilver. You have patients that have that Herxheimer reaction, which is very similar to the endotoxin reactions as well, too, when you start looking at the symptoms. So I want you to kind of dig a little bit in those.
Okay. So, Herxheimer, Jairus Herxheimer, named after a German and Austrian physician back in the early 1900s. They actually discovered this with syphilis, a spirochete, pretty much any spirochete. So the way this occurs is if there's a large death, either from antibiotic of a spirochete, it will give off a toxin. It's because of it's because of cell death, a high amount of cell death. That's what causes Jairus Herxheimer reaction. And yes, it can occur in few other things, but not the greatest majority is because of whether you're treating Lyme, some other spirochete, because of their cell death, it will give off these toxins. It will increase the cytokine storm. It is pretty much self-limited for the most part. It's a 1 or 2 day experience. Put that aside for a minute. The endotoxin's a very different animal. Maybe not in the presentation, which you said correctly. But the endotoxin comes from gram-negative bacteria, toxins, which, by the way, are in your sinks. So even though you need to have a sink close to where you're mixing, it has to be 6 to 8 feet away, according to OSHA and everything else, so you don't end up with endotoxins. That's why people tell me, oh, I go to people's houses and I mix right there. It's insane 101. So I tell them, okay, so endotoxins are pretty much everywhere. So the human, 70-kilo male, let's say, healthy, can handle up to about 350 endotoxic units per hour. Just keep that in mind so you get a feel for it. A smaller woman, a child, no. So everything has endotoxins. So the fluid, the diluent that you're using, regardless of what plastic bag it's in or not, has about 0.25 to 0.5 endotoxic units per ml. That starts the problem. Now you take things, vitamin C can have anywhere up to 0.5 to even up to 3 or 4. you should be asking once in a while your compounding pharmacist that you're using, give me your endotoxic testing. I want to know what it is because you need to have in your head. So here's an example of knowing how much you're putting in the bag to get that endotoxic shock that you can have. And endotoxic shock goes from that rigors and chills and things that look like Hersheimer to something that could be intensive care worthy.
Right.
So you got to be careful. And the endotoxins, by the way, can also be cumulative. So, for example, if you give 375, they handled the 320, the 50, there's 25 left over, not enough to cause a problem. Then the next hour you're given again, it can accumulate and you can go over the amount that can be taken care of by the body. So everything's going to have that. You should get a handle of how much you give it. What is the key not to get endotoxic shock? Very simple. Slow the heck down. Yahoo work does not work in IV for many, many reasons. Cells do not take a good drink of this fluid unless it's given slowly. My rule, is no more than 1 to 4 mLs per minute unless you're rehydrating because of an emergency like you guys would do. But in a clinic where you're treating chronic disease and you want to get a net result that has efficacy associated with it, 1 to 4 drops. Now, most clinic want to turn the chair. They don't have enough. They want to get going. The nurse wants to go home. The person's in a rush. They turn it up. I'm sorry. That's what causes endotoxic shock. And here's what happens for the doctors listening and for the folks listening. It is severe chills. You get a fever. It's not maybe as high as the Hersheimer reaction, but you will get a fever. It becomes and
cramping, all kinds of stuff.
All stuff.
Yeah.
And the chills are so bad, you can pile on these folks blankets and break every hot pack you have in the place and all the things that you have. You just have to wait it out.
Right.
With the knowledge that, yes, you need to keep a KVO, keep the vein open. Yes, you probably should take that fluid off and have it tested for it. Yes, you should put some other fluid on that's low, that you know which fluid is low, and just keep it dripping very slowly. Because remember, you keep adding, even from the fluid, you're adding more and more of the endotoxins into the system. So the key is just go slow. Don't be stupid. It will happen to everyone who does enough of them in their career. I remember the call with it, and I told you, I know what this is, and this is what you do. Relax.
Oh, no, you hit the nail on the head. You was like, Sam, it's endotoxin. It's like, then I started like reading up more about it. It's like, man, how does Dr. Mitch know so much?
Appreciate the compliment. And the key is basically if you go slow, wait it out. The person will be okay. You can give them hot liquid. You could do all of that. The problem is you're still going to wait until that body handles those endotoxic units. And after you lose the patient, because they won't come back to you because they'll think that you poisoned them or something, if they do come back by some wonderful means, realize that you need to go much slower. Right. That's why I said keep 1 ml to 4 mLs an hour. You won't get to that endotoxic level. I know because that's how I keep people safe.
Absolutely.
Okay.
Doc, methylene blue.
Yeah.
I know you use it, but do you use it intravenously?
No.
Why is that?
You have something to issue. Me, I go safety and everything else. I think, methylene blue is anywhere from 1 to 2 milligrams per kilo. Some go even higher, 5, 6 intravenously. It's mostly anecdotal data. It helps the mitochondria people feel good. It is a dye. And yes, I do believe that it can improve the mitochondria in certain areas of the mitochondria complexes. It does. And orally, I typically never will give more than 5 milligrams. But here is the issue with intravenous, other than the factors, the literature scant. The first thing is it will turn the urine quite blue. It's not a bad thing. It's not, but it does. It was meant for methemoglobinemia. You know that. Right. You use it as an emergency. Outside of that, it can actually, especially people taking SSRIs or anyone, it can cause a serotonin syndrome.
Right.
That can make someone nuts. It makes them hot. It makes them crazy. They can convulse. Why? Why would you do that? You can make them mentally foggy and everything else. When you'll probably get the same result using a much smaller dose. You actually can cause the liver to be damaged as well. And because we don't know the right dose. And again, to repeat earlier conversation, if they have a G6PD deficiency, no amount is known to be safe. At 5 milligrams, could it happen still? Yes, but it's on the very low end. You start putting in the arm without a G6PD, again, I'll go back to, I think that person should be horsewhipped.
Yeah, yeah. So guys, if you're listening here, I know a lot of clinics are offering IV methylene blue. Be very cautious. There's other alternatives. Maybe you don't have to go that aggressive when it comes to that.
You don't, and one other thing, Sam, it's a gimmick. It's new. It can help. But again, I would ask the same clinics, why'd that person need methylene blue IV? Oh, because it'll help in what? Help what? Well, it'll help their mitochondria. And I said, okay, how'd you know their mitochondria are bad? Now, I do, just so you know, I send a screen to California. I know what someone's mitochondria are doing.
Who do you utilize for
Me screen?
Okay.
Yeah, I do
We were using a lab out of Germany, man. The IGL test. I don't know if you heard of it. It's
You
no
like
longer,
it?
It was the best test that our doctors were utilizing, where it actually showed all of your mitochondrial clumping, mitochondrial potential.
So that's what you need.
It actually, this test, which is interesting, I'll show you a sample after we're done with the podcast. It actually would test for over 900 different toxins, but it would show that DNA adduct and what gene it was actually bonded to.
Oh, interesting. They gave you a lot of information.
Yeah, a lot of info.
Sometimes too much information, but I'd love to see it. I would.
But the guy, the owner, he passed away, and all of a
it's
sudden
gone.
everything's gone.
Well, Me Screen is a very good test. Look, I'm not, I do an awful lot of work with them. They know me. As a matter of fact, I was on the phone with the owner today. They like to check in with me and what I want to do because I'm in that cancer area and I know what things to look for in that area. But you see, it does give me a sense because people don't realize the mitochondria is responsible for 80% of the reactive oxygen species. So if you have very low, giving more antioxidants may not be the best thing. If it's very high, you need to give more antioxidant. If the potential is bad, or it changes my IVs and my approach. And for example, I can get a very good result, particularly because I use a lot of molecular hydrogen. I'm the chief medical officer for the best molecular hydrogen in the world. And I know I'll get amazing results with it because I can look before and after in these screens.
Nice.
But the question is always, why are you doing it? Again, I always beg the doctors to be able to tell me why you're doing it. If it's just nonsense, like because they need more energy or something, I'm sorry, I'm not buying that. If you could tell me specifics physiologically or biochemically why you're doing something, then 6 months from now, like I said, you'll be able to tell me again.
Nice. I like that. So now that we're talking about some of these different IV treatments, right? Not your typical just vitamins, minerals, and amino acids. I want to talk about the silver.
Okay.
Silver hydrosol. You've utilized it. You've actually have taught when it comes to utilizing silver for certain illness, viruses, etc.
Yes.
So let's go a little bit deeper into the silver and how it's utilized.
Yeah, I will. I can quickly do it. Silver is an antiseptic. It's antibacterial, antifungal, and it's also antiviral. It's like alcohol. It kills everything. No antibiotic can do that. No antifungal can do that. None of them sit in that antiseptic category. That's number one. Silver's been used, and it's in the Bible. It used to purify water. The astronauts use it to purify their water. So silver sits in an area. Some people will say, but isn't that a heavy metal? Well, first of all, you misnomenclatured it. It's actually silver is a transition metal anyway, and a heavy metal is not necessarily toxic, and a toxic metal is not necessarily a heavy metal. Probably a discussion for another time. So silver actually acts against pretty much everything. The viral capsid, it will break. It has no tachyphylaxis. You can use it over and over again. It will kill the bacterial wall. I mean, it just is that good as an antiseptic. And unfortunately, if it's topical and you want to have, like, you have a nasal, you have a sinus problem, you put it in, nanoparticularized silver will go right across the bony ridges, go in. It's nanoparticularized. It will do a great job. You're on a sore throat, that kind of thing. Holding it in your mouth for several times will end up going into the organ systems, but about only 5% of that will get into the actual general circulation. You need intravenous to do that. Now, there are different types of silver. The only silver that you can use safely, intravenously, and well, and again, I probably taught pretty much anyone that's using it in the country is my student. The only one that you can actually use safely is a nanoparticularized silver for several reasons. it usually has there's only a couple I would ever use. It gives a very smooth appearance and coverage when you look at it under a electron microscopy.
Mm.
So that's the first. Other silvers cause dot and blot. If you look at silver chloride, for example, it will be dot and blot. And that's the kind of thing that causes argyria, which causes that blue smurf that can happen.
Right.
With nano silver, I use 25 parts per million. That's really 25 milligrams per 1,000 cc's of it. You're nowhere close to the LD anything. Let's put it that way. You're not even close to anything that would cause a problem. You're so far from it. So it's very safe. The problem is it's extremely hypotonic. And as we discussed, hypotonicity is an issue. So because it's so hypotonic, it's extremely irritating also to the vein. Little bits are okay. Large amounts require a PICC line or a port to be able to give it effectively. You must give it slowly. I absolutely maintain the rule that you must only give it 1 to 4 cc's per minute maximum. Takes time. Too bad. This is not a race. You want to get better.
Right.
And yes, I use it against different things. I've lived in Africa. I've lived across the world in several places and doing work. And I actually sat with the former prime minister, as close as you and I are, on a G4 going back over when we went. And we were talking about Ebola and stuff like that. Meanwhile, I'm there, and there's an Ebola breakout.
Oh, wow.
Which really didn't worry me, really, to be quite frank. There was an Ebola breakout in Sierra Leone after I got back, and I literally was talking on the ground to the people. And I don't know if this is gutsy or downright stupid. I said, I will come. I will bring a team. I'll bring all the equipment. I'll bring everything. And I think we can save most of these patients by use of very high dose vitamin C, which definitely works in hemorrhagic disorders, and using silver. And I was going to do it around the clock. And everyone around me said, Mitchell, are you out of your mind? You would go where there's Ebola, because Ebola, as the former prime minister told me, kills everything in the forest except the mouse.
Wow.
And that's how I thought this theory out. Wait, the mouse doesn't die? That rodent? That's because it makes its own vitamin C. I got it. I've got this. So I said, I got this. I would do it. I literally talking, like you would see on a movie, like I was there on Mars and I'm on the ground. I said, I'll put the whole team together. I'll get all of it donated. I said, I'll get people that are not afraid. We'll get hazmat. So we'll do the right thing. You think I ever got there? No. Never got there. And I will leave it to the imagination, because you are so intelligent. You'll get it immediately. The other people out there, I will tell you, politics doesn't care about life or death.
Right.
I'm ending it with that. I won't say another word.
Yeah, no, enough said on that one for sure. So Doc, as I got another question here for you. We've covered primarily all of the topics that I wanted to discuss, but there's a huge trend right now that's happening where people do the NAD drips for the brain reboot. Because it helps them with cognitive health.
Yes.
But now there's True Niagen came out with an NRIV drip.
Mm-hmm.
So in what they claim based off of their clinical research is that the NRIV drip, number one, you can do it a lot quicker than the NAD. And
That's
number
true.
two, that the NAD levels intracellularly are much higher than doing NAD by itself.
So the question is that true? I'm not sure. The literature is very, very poor. Part of it's theirs. Is it true? Maybe. But what we probably don't realize is when you increase the plasma level using NAD plus to begin with, you will get a shift. That shift takes several hours. It doesn't go directly inside, but it will happen. If you're using it sub-Q, for example, talking about NAD plus directly, it will also go in over several hours. So I'm not sure that's totally true, but here's the problem. We make the equivalent of the NAD. Our stores are about 3,000 milligrams a day. So we try to maintain, when we're healthy, we don't need NAD. We'll stay. You get older, whatever. You may need more. Obviously, the mitochondria, it's needed for mitochondrial ATP exchange. So the problem is you're using, NR, which is part of the salvage mechanism. There are 3 mechanisms for making NAD. There's the price handler, there's direct de novo synthesis, and there's a salvage, which is probably does the most of it. NR does a very good job in the salvage. I actually, I'm actually also a CMO of pretty much the number one NAD in the country. It's literally the best. It comes from Korea. It has only two components in it that are not, or contaminants, I should say. All the rest that we use in the United States have 9 to 11.
Oh, wow.
It's a much better. It's 30% more effective.
Where can people find this, by the way?
They can find it. The product is called Nadvit. And I don't have problems sharing anything. You know me, I'm an open book.
Yeah.
You call me. And I will share that with you if you need to share it with your folks out there. And Nadvit's an amazing product. I actually just made the oral formula. If you notice any of the oral formulas, you probably take them. There's 2-3 things in them, some NR, the NMM.
Right.
But this product that I'm making has 13 because it hits all the pathways.
Oh,
It will
really?
be out in 2 weeks.
Wow.
It is not good. It is the best, the best. Nothing
want
will
it.
do. You want it, and you want to give it to your clinics and
Right.
stuff. And you and I will talk about it, make sure you get it, and whoever else is listening can get it. And by the way, folks, I don't have any interest in what I'm telling you. Yes, I am they pay me. I'm paid. I'm not saying I don't get paid, but I don't get paid more because I developed
Right.
it. It's my IP that they get. So that's, which is fine. They're great guys and they're doing a great job. So here's my issue to your question. I'll answer your question. When you do take a lot of NR, there is a potential for liver toxicity. Yeah, it takes a lot, but there is a potential. When you have a lot of NR, you use up methyl groups. So if you have someone who's a poor methylator to begin with, has high homocysteine, we discussed, they're going to get even higher homocysteine. And every point pretty much that you're over 6.5, I've read in the past, how true this is, I think it still is, it holds. It's no question it is a factor for heart disease by itself. But over 6.5, pretty much for every point, you have 6 times more heart disease and stroke risk. So if you're using up even more of this, of your methyl groups, and you have that issue, and you can, when you have too much, it often doesn't hit the salvage pathway again. I'm not sure I'm ready to be in that space. I would rather use the oral form, which has NR in it. I've used
Right.
NR in mine. I like NR. It's a good base. But using it IV, is it a gimmick? Yes, it is faster. You're correct. It is less painful. It does increase cellular levels faster, but I don't know over time. Just because you increase something in 2 seconds doesn't mean what happens 5 hours or 10
Right.
hours. There's no study on that. So me, I'm still into the NAD. Would I throw it away and say, oh, it's not going to happen? I would never use it, Mitch. No, I may look at it later on. But for now, I have such great results with this NAD that we use and with this new product that we've made. It's just that good. I would say always be cautious what you don't know enough about.
Right.
And if I just said something that didn't make sense to you, like you've never heard that pathway uses methyl groups, and hence the product I'm putting out has a methyl donor in it. Yeah, you need that. So, and since there's so many people that have this MTHFR that has expressed itself with elevated homocysteines, you better think 3 times because you could fix one thing and you make another bad. Would make
Yeah.
no sense.
Yeah.
It is an independent risk factor, homocysteine.
So with time, we'll know if, with
Yeah,
more
let's
research, right?
Give it time. We're not in a rush.
Yeah.
We want to do things right.
And especially if you got things that are already working, why
Yeah.
reinvent the wheel? So, Doc, one of the things you just mentioned is like, if you don't know enough about something, right? That brings me to the next topic. So we know about CBD. There's a lot of research on CBD, oral, topical, etc. There's a lot of FDA approved companies or big pharma companies that have synthetic versions of CBD for different illnesses. There's a company that recently came out. They pride themselves as being the first sterile CBD for intravenous use.
Mhm.
And they've created it to the picomolecule, which is smaller than the nanomolecule.
It is.
To really get into the cell in different parts of the body, like the brain, etc. And they have a group of oncologists that are actively utilizing it, and they're seeing some tremendous results. Do you know anything about CBD being utilized intravenously?
No, I've never used it intravenously. Of course, I'm very aware CBD patients take it and so forth. much like THC, CBD has some very positive things. It will lower interleukin 6 to a certain degree, tumor necrosis factor alpha, which are transcription factors for inflammation. It does help people relax, help them sleep, but they're the opposite side of the spectrum. I also know that, for example, cancer is fought in a T helper cell 1 state. And actually, use of large amounts or using it if you're using once or twice a week, I don't care. Using it ongoing, it actually can change that state and decrease the T cells and the T helper cells. Now, I try to improve that situation when I have a cancer patient. How do I do it? I may use the old Tagamet, cimetidine in large doses. I may use rapamycin once a week. In other words, I'll do things to improve that. I don't want to use. Why would I do things that are counter balancing each other? So again, it's not something I would say I would never use, Sam, but it was something I would say, like you and I agreed on earlier. Look, we have other things right now. Let's wait and see. Everyone's looking for the next gimmick and the next
Right.
thing, which is okay. Sometimes they're very good, and sometimes they're me toos, and sometimes they're downright probably dangerous. So I'm going to hold on that. And don't get me wrong, I'm an innovator. I use products I've put together. I've made the formulas. But I always have to understand the biochemistry of it perfectly. Yeah, picoscalar is very small. It's in billions. It's tiny, tiny something. And yes, we'll get into the cells. So does that mean it's going to do damage? Does it mean it has any toxic metals? Does it mean it's going to displace something? Is it going to mean it's going to make them sluggish? Does it mean it's going to turn down my immune system for these patients that
Right.
require a really good? I don't know. And until someone shows me that literature, I won't use it, but I'm not throwing it out. I'm just saying caution. Let's
Right.
step close. Let's
Let's
step
get
and watch.
let's get the data.
Let's
in,
watch.
In
Let's
God
see.
we trust. Everybody else produce data.
Yeah, that's exactly good. I like
Yeah,
that.
yeah. So Doc,
Yeah.
the next take here, I want this to come from the heart.
Okay.
I want you to take the next minute or two and let the world know what is the problem and what is the potential solution for the problem with everything you do.
Okay. So let's do that. Thank you for asking. I think that's a good question. I think we have a major global health issue. The United States is way behind the rest of the world when it comes to longevity. If you look at the longevity figures, it's not good. And yes, yet we're the most technologically advanced country in the world, and yet we can't produce that. Why is that? So are we approached medicine the wrong way? Have we really looked at prevention from really a healthy way? Have we really looked at those cycles that you and I, Sam, spoke about tonight? Have we looked at them, Krebs cycles? Have we looked at the mitochondria? Have we looked at making sure that our biochemistry is imbalanced? Have we looked at the foods we eat? Have we looked at the things that we've injected into our bodies? Are we doing what it really takes? Using buzzwords like let's eat cleaner, this type of thing, that just doesn't work. We really need to get a good handle on our biochemistry. We really need to use things that make a difference. And the only way you're going to know is by doing a good enough workup to be able to tell. We need to go back to the future. If we go back to the future, reinstate the concept that there's something about indigenous medicine, there's something about herbal medicine, there's something about nutrient therapy that really, really makes a difference, that this is our cement, this is our basis of life. Then once we realize that, as practitioners, we'll be able to change the global problem of healthcare, and we'll be able to give life to our patients, not just in the form of quantity, but the most important is quality.
Amazing, amazing. Doc, last thing here, one of my favorite podcasters, Stephen Bartlett, with A Diary of a CEO, he came out with these conversation cards. So I want you to go ahead and open it up,
Okay.
grab one from the middle, read the question, and answer it.
Okay. This is like a fun game we're playing here.
Yeah, a little fun time here.
All right. Oh my gosh. One of the cards. No, where's the question? How it works? Which one?
You got the Joker card. Pick another one.
Oh, I thought now I can answer whatever I hell. Well, please. All right. I thought that was like weird. Is this a test for me? I'm thinking
We're gonna have to take that one out, actually.
All right. Diary of a CEO. What was the most valuable lesson you learned the last year and why? Okay, so I've got to keep it to last year. Is that the idea?
Yep.
I'm not allowed to go beyond it. Most valuable lesson I learned from last year is that you have to take time to smell roses. I'm a workaholic, Sam. I'm working harder now than at 75 than I was when I was 31. I recognize that I'm needed. I need to help. Um, I realize that I need to start handing down the stuff that's in my head to others. Um, People say, look, Mitch, if you're not there, no one else is going to be able to do what you do. Yeah, there is. I just need to hand that down to someone else. I have an amazing wife. I have 8 children. I have my 10th grandchild on the way right now.
Wow.
There's something that you never ever can take out of the medicine and your life space, and that is you need to take care of yourself to be able to take care of others. I've learned that lesson, and because I had a little bit of a scare this year, which turned out to be nothing, thank God. And with that, I realized how important it was to communicate with my kids, my grandkids, especially my wife, and realize you have to laugh every day. Just laugh. It increases your immune system. I'm actually very dear friends with the people that did all the work on laughter therapy, and then increases the immune system for the next 12 hours in every area of the immune system an area. And I realized that that's what I need to do. I like to stop and laugh. I made a agreement with myself this year, and I'm asked to lecture and do and teach constantly. I have a company that teaches doctors, and am I allowed to say my website? Would that be all right?
Oh, yeah.
Oh, it's genmed.com, Ghen med, M-E-D, all one word, GHENMED.com. But I realized that I have to keep myself healthy. I have to think about it, and I have to create in my head that ongoing communication, just like anything else. You want something to be good, you want the flowers to be, you have to water them.
Right.
So I'm going to water my relationships, and there's no question. Look back at the Harvard's Med study, the longest running study. What was the one thing in common, even after 70 years, and it's still running, was your social interactions.
Wow.
Having things like this with amazing human beings, having a nice friend in you and over the years. These are the things, sitting here with a
Community. Community is so important. Yeah.
That's it.
Yeah.
That's what I learned.
And Doc, is that where people can find you? The website that you provided?
Yeah, they can. And of course, that's the best way they can contact me. Easy to write me that way. And there's an info section there. It's called genmed.com. And it's really also for physicians and training and things of that nature.
Right, right. And Doc, as we wrap up here, if there's someone that's listening or viewing the podcast that resonates with today's message, what is that one thing you can leave them with?
Well, the one thing to leave them with in the IV space, I'm think you're asking.
Yeah.
Don't be afraid of it. If you really want to do what's best for the patient, which I thought we all did when we went to medical school, we might have gone astray. We need to make money. We need to repay it, whatever. But if you really want to be the best physician that you be, not a great physician, then take yourself 3 years, even while you're seeing patients, to incorporate one of the most important modalities there is for helping someone's normal body mechanisms to work properly, and that's IV therapy. Reach out. I'm here. There's other people. Sam's here. Reach out and begin learning it properly. Do it properly. It will come back to you. It's like anything else. What you give, you get back 10 times. So give to your patients, help them, and you'll get back.
Amazing.
That's my word of the day.
Doc, it was a pleasure having you
Thank
on
you.
a Healthy Point of View podcast. Thank you.
My pleasure. Thank you. God bless you.
Thank you. Guys, you heard it from Dr. Mitch. It's not about having a medical provider or being a medical provider who's good. Shoot for great. Find the greatness. And the way that you get there, it's not just one thing. Number one, understand the body. How Dr. Mitch said, go into the biochemistry of the body. Learn about the things that we were talking about the Krebs cycle. Make that part of your medical practice. Find a medical provider, if you're a consumer, who understands these things. Guys, we all know that you have some kind of friend or family that can benefit off of today's podcast. Make sure you share it, like, subscribe, do all that fun stuff, and we'll see you for the next one.